DNA repair defects in Olaparib in metastatic prostate cancer. Definition: prostate cancer begins when cells in the prostate gland start to grow uncontrollably. The prostate is a gland found only in males. It makes some of the fluid that is part of semen. The prostate is below the bladder and in front of the rectum. The size of the prostate changes with age. In younger men it is about the size of a walnut, but it can be much larger in older men. Prostate cancer metastasis occurs when cells break away from the tumor in the prostate. The cancer cells can travel through the lymphatic system or to the bloodstreams to other areas of the body. Metastatic prostate cancer is an advanced form of cancer. There's no cure, but you can treat it and control it. Cancer Research UK.
Prostate cancer is the number one cancer amongst men in the UK. So with that in mind, I've come to Cambridge University Hospital to speak with Dr. Vincent Nunaprakasam to find out more. So, Vincent, where exactly is the prostate and what does it do?
Well, the prostate is effectively a very large gland, and it sits between the bladder and the urethra, which is the pipework. It produces fluid that washes the semen and keeps the sperms healthy for successful fertilization. And that's what the function of the prostate is.
So what happens when cancer develops in the prostate? Where does it grow?
It usually begins within the edges of the prostate and can occur in more than one place. It starts to grow inside the prostate first of all, and when it gets advanced enough, starts to go through the lining or the edges of the prostate.
Now, this is a cancer that affects men and not women, but does it affect all men equally?
Well, there is an old saying that the older you are, the more likely you are to get prostate cancer, and that's probably true to a certain extent. There are other risk groups which we have to think about, and that includes ethnicity. So we know that black men, for example, are more likely to get it. Those with a family history of prostate cancer, usually a father or a brother, first-degree relative, as we say, and those who come from families where there might be increased risk of breast cancer.
Now, the numbers of men being diagnosed with prostate cancer has risen, hasn't it? Why is this?
Well, it's probably not anything that's new in terms of something that's happened to men. Clearly, men are living longer, and as I mentioned to you before, the older you are, the more likely you are to get prostate cancer, and that's probably why we are detecting many more cancers. In addition, more men are seeking to know whether they've got prostate cancer, and they might go to the GP and ask for a test to be done, or they may have urinary symptoms, which is a very common thing for an older man to get, and as part of the assessments, they may be found to have prostate cancer. But there's no doubt that those factors have contributed to a very significant increase in the numbers of men who seem to be diagnosed with prostate cancer. The encouraging thing, though, is that deaths from prostate cancer are falling.
As prostate cancer is one of the most common cancers, it's something we should all know more about. For further information, visit the Cancer Research UK website, or if you're concerned about the symptoms, the treatments, or living with prostate cancer, see the other videos in this series.
Applications in medicine. Metastatic castration-resistant prostate cancer can have genomic aberrations that interfere with DNA repair. Some of these aberrations have been associated with sensitivity to platinum and folate inhibitors, suggesting that treatment with PARP inhibitor may exploit a synthetic lethal interaction. PARP is involved in multiple aspects of DNA repair, and the PARP inhibitor Olaparib has recently been approved for treating ovarian cancers with BRCA1 mutation.
Prostate cancer is a heterogeneous disease. Genetic testing is not currently part of the treatment algorithm, but could DNA repair defects influence the response to prostate cancer treatment? The authors of this study hypothesized that metastatic, castration-resistant prostate cancer in patients with DNA repair defects would respond well to poly-ADP ribose polymerase, or PARP inhibition, with Olaparib. 50 patients with metastatic castration-resistant prostate cancer were enrolled in this phase 2 trial. All 50 had previously received standard therapy with docetaxel, and 49 had received either abiraterone or enzalutamide. In the trial, they were given 400 milligrams of Olaparib by mouth twice daily. Tumor biopsy specimens were examined for known DNA repair defects. Of the 49 eligible patients included in the final analysis, 16 had an objectively defined response to Olaparib. Of these 16 patients, 14 were found to have a DNA repair defect. Anemia and fatigue were the most common severe adverse events with Olaparib. The authors speculate that if their results are replicable, patients with DNA repair defects will have a response rate to Olaparib on the order of 80% or better. Full trial results are available at NEJ.
Pros and cons. Pros. Evidence for the antitumor activity of Olaparib in this study cohort includes concurrent falls in PSA levels and circulating tumor cell count. Response to treatment commonly lasted for more than 6 months and were associated with prolonged radiologic progression, free survival, and impressive falls in circulating tumor cell count. However, we cannot yet determine whether Olaparib improves overall survival among patients with metastatic castration-resistant prostate cancer and repair DNA defects. Cons. A notable finding of this study is the response to Olaparib in patients whose tumors had monoallelic ATM aberrations with mutations affecting the kidney's catalytic domain, despite the continued presence of the second allele and ATM protein expression on immunohistochemical assessment. Multiple studies have described how the loss of one kidney domain can alter ATM protein function. Aberrations in multiple other DNA repair genes associated with PRP inhibitor sensitivity may be present at a low frequency in metastatic castration-resistant prostate cancer, as reported in other cases.
Olaparib is probably the PARP inhibitor for which we have the most data right now in prostate cancer. It was studied in the 2-PARP-A study by Johan Dubono's group. It was very exciting, published a few years ago, and there's ongoing studies with Olaparib and with combinations with Olaparib. So in that study, at least, men were selected to be included in the study as long as they had undergone actually multiple prior therapies and were really sort of treatment refractory at this point. They underwent biopsies before being treated with Olaparib, and then they were followed, and they were assessed for PSA response and for progression. And in this study, for patients who had DNA repair defects, and this was looked at after they were already on the drug, I believe the response rate was around 88%. And response included, was mostly based on PSA response in this study. But that's a really high response rate, very exciting, higher than we would expect in a regular clinical trial, and there wasn't a randomization. This was a single-arm study. Patients who did not have DNA repair defects didn't seem to respond in that way. All of the patients who had BRCA2 mutations did appear to respond. So these were all really exciting things. And so Olaparib in prostate cancer, at least, is pretty far along in its development and its initiation into further clinical trials. And the other PARP inhibitors are on their way, but that's the Olaparib data.
Issue applying in Ecuador. In Ecuador, the incidence of this type of cancer is high. In addition, 90% of men develop benign prostate hyperplasia or inflammation of the organ without becoming a malignant tumor. The drug use, Olaparib, had until now a low success in average of cases, but it did manage to delay the growth of tumors in 88% of the patients with specific DNA mutations. The future of cancer medicine is increasingly based on the treatment of that disease from its DNA mutations rather than where it is located in the body. For example, the drug that attacks breast cancer, herceptin, is already used only in patients with specific mutations. The drug Olaparib fights mutations that modify the way in which DNA is repaired.
The really evolving information we're getting with respect to drugs that can be used and the kind of results we have seen recently with using PARP inhibitors in patients with so-called DNA damage alterations. And I talked about the fact that approximately a quarter of the patients have been shown to have these with metastatic cancer, prostate cancer. And it's important because use of an agent like a PARP inhibitor is a different treatment paradigm, and we have not used PARP inhibitors much before in prostate cancer. They've been studied and approved for ovarian cancer, but not for prostate. So if we know somebody has this kind of alteration, I think we're going to start going the PARP inhibitor and or use of platinum and platinum-like agents like carboplatin, which have also been shown in patients with DNA repair defects to be effective in ovarian cancer. So, we're assuming that they're also going to be equally effective, perhaps as PARP inhibitors in prostate cancer, but that still hasn't been shown yet.
Well, in conclusion, we report that PARP inhibition has anti-tumor activity in sporadic cases of metastatic, castration-resistant prostate cancer, and that this disease response are associated with DNA repair defects in tumor cells that can be identified through next-generation sequencing assays.
My lab here in the Gurdon Institute is focusing on how cells respond to and repair DNA damage within the cells of our body. We're interested in this from an academic perspective, but for many years we've also been very interested in the idea that out of this new knowledge that we're generating, there could be therapeutic opportunities for new drugs, for example, for cancer, but also for other diseases. So the developments that we're talking about today relate to a brand new anti-cancer drug called Lynparza, also known as Olaparib. And what this new drug does is work against serious ovarian cancer through a mechanism that has not been exploited before in the clinic. The basis of this new drug is to target DNA repair pathways within human cells. So it turns out that every cell in our body is sustaining DNA damage, and that damage needs to be recognized and it needs to be repaired. Because if the damage isn't repaired, the cells of our body die. DNA is a genetic blueprint which needs to be kept intact. Now, the way that works within our cells is that every cell is sustaining DNA damage, but there are certain proteins in the cell, molecular policemen, if you like, whose job is to carry out surveillance, looking for DNA damage, and when it occurs, to recognize the damage and then repair it.
Thank you.